Hello everyone, welcome to tonight's Nordocs webinar, Understanding Autism Without the Disorder. My name is Dr. Peter Silberberg. I'm a GP at the Lennox Head Medical Centre and at the Aboriginal Medical Service Rekindling the Spirit in Lismore, and I'll be your presenter for tonight's webinar. I'd like to acknowledge the traditional owners of the land on which we meet today, the Bundjalung Nation, and pay my respects to elders past, present and emerging, and to any Aboriginal people attending tonight's event. I'd also like to thank our sponsors for tonight, Southern Cross University. Nordocs is a not-for-profit organisation that relies on sponsorship to run these education activities for its members. And just a reminder that Nordocs is a network of all doctors, including GPs, specialists, doctors in training, including medical students, living or working in our geographical footprint that extends from the Queensland border to Grafton. And one of our aims is to support all its members by improving the health of our North Coast community, which includes education such as these webinars. And just briefly, before we move on, I'd also like to make an acknowledgement that this webinar is currently being recorded in the midst of the biggest known natural disaster to affect the Northern Rivers. And this has touched every person in the region, and our thoughts with all those who have been tragically affected. So I've got some fantastic guests with me tonight to help explain autism. I'll start by having Professor Andrew Cashin introduce himself. Welcome, Andrew.
Yeah, hi Pete, thanks for having me, and hi to everyone out there. I'm Andrew Cashin. I'm Professor of Autism and Intellectual Disability in the Faculty of Health Science at Southern Cross University. I'm also a mental health nurse practitioner and an accredited NDIS provider of therapeutic supports, and run a clinic for people with autism at the Southern Cross University Health Clinic in Lismore.
Fantastic, Andrew. Thanks for being with us. And we also have Dr. Matthew Snow.
Thanks, Peter. Hi, everyone. I'm Dr. Matt Snow from JMS Allied Services. I work here primarily as a behaviour support specialist, working with children in a majority of my cases who are on the Autism Spectrum Disorder.
And you work down in Coffs Harbour, is that right, Matt?
Yeah, correct. Yep.
Yep. And Matt's had his street electricity go out tonight from a car accident, unfortunately. So he's running off a 12-volt battery, and we've worked out a way to get his computer going. So if he drops out, we'll get him back briefly again. So thanks for being there, Matt.
No problem.
So look, we hope to cover quite a few things tonight for you. Would really be pleased if at the end of the event that you have a better and increased understanding of autism. We look forward to hearing a lived experience from a parent of a child with autism, and we want to improve your understanding briefly about the NDIS application with this problem. And then lastly, we'll try and have time to cover some handy tips for interactions with patients with autism when they're with you in your consultation. So we're going to start with a true or false game. We've done this before in these webinars, very effective. So I'm going to start with this one to Andrew. So Andrew, autism is a condition that mainly affects children. True or false?
Yeah, I'm going to go with false, Pete. Autism is actually a lifelong disorder, and whilst the previous edition of the DSM and the ICD actually stated that it had to be recognised prior to the age of 3 to get a diagnosis of autistic disorder or Asperger's disorder. That's changed now in the DSM, and we realise that it can be recognised at any point in someone's life, and it's recognised when their person's context and their stresses outweigh their ability to adapt. What's interesting, though, is that the way we've got to this point historically has meant that we're far more service rich for children than we are for young people and adults, and that actually 98% of the funded research internationally is being conducted with children. So that recognition that it's a lifelong disorder is particularly important. And we're rich with paediatricians in the area, some really great paediatricians. Often there's going to be a really strong role when people with autism get beyond the age that normally fits within that trajectory of paediatricians, that will have a role for GPs and all medical providers.
That's great, Andrew. And just to stress the point there that sometimes autism isn't picked up as a child, and then of course it's not until the person becomes an adult that they may investigate the possibility. So that's great, thank you. And we'll go to the next one. So this one's also for you, Andrew. So the ratio of male to female people with autism is between 1 to 3 and 1 to 2 if you include an accompanying intellectual disability.
And again, this is really worth pulling apart as to whether it's true or false. It's hard to answer, and it's partly how we research things. Research that's prospective and actually does assessments as part of the research finds a far greater incidence. We know that there is some sort of genetic link, just like we know it's heritable. If you're a dizygotic twin, you're more likely to have autism than if you're a monozygotic twin with a sibling with autism. But we can't exactly say what the genetic mechanism is, but there seems to be some maleness associated with it. But the other tricky thing is that it took us a long while to realise that autism can look different in girls for a whole range of different things, and we can talk more in depth about that later on. And the other interesting thing is how we think about intellectual disability now. And we've really shifted in the DSM and the new ICD to talk about intellectual disability as a comorbidity. And again, as our diagnostic vision shifted, we went from both Kanner and Asperger talking about their samples being largely of normal intelligence, which was, I guess, the words that, you know, were palatable at the time. Clinicians then moving through a phase of wanting diagnostic certainty and recognising more intellectual disability than the autism, to the point now where we've got a fairly good idea what autism looks like. And so we've flipped over from a significant majority having intellectual disability to now a significant minority. And that's around 30%, which is just over 10 times what would be the community incidence of intellectual disability. So again, there's some shared mechanism of vulnerability, but that's beyond our understanding at this point to say what that is.
Yeah.
And Andrew, can I ask you there, so if I had a parent who has a child with autism and they were wanting to have another child, and they asked me as their GP, you know, what's the risk, or should I be worried, you know, do I need to think about autism in another child? What would you answer? Yeah,
I mean, we've only got an hour, so I think I'd be really careful how I worded it. But it is heritable in that if you have one sibling, the chances of having another sibling is higher than if you didn't have a sibling. And we know that it runs in families, if you like. If you have the other thing we talk about is the broader autism phenotype, is that if your child doesn't have autism, they may have symptoms that look similar to autism but don't meet the full diagnostic threshold. That'll take us a while to think about it. Really, if you have the risk that we know about in terms of heritability, and there was a pot of gold on the other side of the street, a lot of us would make a dash for that pot of gold. And so talking about actually, well, what we know at the moment to be the size of that risk of having another child with autism does put that a little bit in context as well. But it's a conversation that is worth having and pulling apart carefully. And because we don't have that solid genetic understanding, you know, except for, I think, and Matt probably knows this better than I forget it, but I think it's for chromosomes 7 and 24 are the only two that don't have a partial dislocation in the research on autism. So there's lots of little changes, but there's not enough for us to be able to do a test and say whether you can or can't with any certainty know whether you're going to have a child with autism.
Oh, that's a helpful answer, thank you. So we'll move to the next slide. So this one's for Matt. So Matt, true or false, autism is a disease or disorder and should be eradicated, prevented, treated or cured?
I'd definitely go with a false on that, Peter. I don't think we should be looking at anyone and their disability as something that should be eradicated. Having the personal experience of having my son, I would hate for anyone to tell me that part of him needs to be eradicated or prevented. I think this comes down to basically a lot of social acceptance and accepting the person for who they are and the differences that they bring. And I can tell you now, those differences that they bring it's really welcoming. I don't know if you guys just saw, but my power just came back on and there's a child above me who's 130 kilos jumping up and down and cheering because he's now got the internet.
Right.
After 5 hours of no power here, the end of it's always, there's happy outcomes in everything. And I think that's the one thing that we need to look at, especially with people on the autism spectrum, or whether they choose to be referred to as autistic. They bring so many great things that it's not all negative,
Thanks for that message, Matt. So we're going to go into a little bit more specifics now. So, often this term has been used, autism spectrum. So this is autism spectrum is linear, with mild at one end and severe at the other. So Andrew, would you say that's true or false?
I'd say that's false, Pete. And we know that having autism is a bit like being pregnant. You are or you're not, and it's a form of neurodiversity. And the degree of autism, or the severity, will fluctuate based on the external demands someone's under. And a really easy way to think about it is a child with autism in the last day of daycare, who's been there for a couple of years, knows the routines, is very familiar, is going to look a lot less behaviourally challenged or functionally impaired than on their first day when they go to kindergarten and they're in a class with another 25 kids and it's all new and different. And so all through the life, the challenges of adaptability will surface. And when those challenges come, of course, what we might think of as severity or the intensity of their autism will look different.
It just makes so much sense when you talk about it like that, to think that we tried to diagnostically put it mild at one end and severe at the other, when it's a constantly dynamic condition depending on where that person is in time. Doesn't really seem to make much sense anymore.
And interesting, and I get excited about this, but there was a book called Smiling at Shadows by Jane and Junie Wakes, and they talked about their experience, which was great. And but it's what we do as typical thinkers. First, we want to know what it is, and then there's a sense of relief, there's a name, then we want to think, well, how did we get there? And of course, autism's been filled with some terrible theories as to what might have been the cause. But then the next bit is how much? Is this mild, moderate, or severe? Because we're always trying to project forward into the future. What does this mean as I look into the future for my child? Are they going to get a job? Are they going to live independently, have children? It makes sense that we do that from that perspective. But in terms of autism, it's not something that those terms are going to be particularly useful.
And so, Matt, you got us to pencil in that line and this graph here to demonstrate something. Do you want to talk about that?
Yeah, there's a great quote from a lady who actually came up with the next slide that we're going to see. And part of what she said is that you can't describe someone as rainbowy just because they're a bit more red. So if you look at this, the picture that we're actually looking at, you might have someone in their perception, they may come right out onto the perception scale of being the darkest of red there, not the lightest of red. That to say that it's a linear scale and that someone is more autistic because they have, less capability on perception and less capability on motor skills, but high capacity on sensory or language and executive functioning, it in the real world, it doesn't translate. So the way that I look at this is that I have a young client who's only the way that his autism affects him is through social interaction and being his sensory overload. He can function with motor skills. He has great perception. He has good executive functioning. He has good language. But if you were to request him to do a simple thing like go to the supermarket with his mother, you have to actually see what it does to him for the next 4 hours after he's been there to believe the effect that it has. So to say that he's on the mild end of a scale anywhere it just doesn't make sense.
Doesn't make sense. Yeah. So yeah, and then the next slide is another way of thinking about this. There's a spectrum again depicted in colour, and there's a little bit more detail underneath that in text about the sorts of behavioural things that you might see in those different areas. And then on the right, someone's given a demonstration of how, you may be more brightly coloured in one area than others. But then again, as Matt says, that can also change. It's a dynamic picture that changes depending on the environment that the person's in.
Yeah.
Did you want to add anything to that, Andrew?
And just and stepping back a little bit from what we're talking about, we're talking a lot about behaviours, and autism is a behavioural diagnosis. That's how we go about it. But the interesting thing about behaviours is what are they the outward expression of? And of course, that's our thinking and information processing style. And there's some basic areas when we're starting to talk about reasonable adjustments or things we can do to our practice to work with people with autism. If you take a step back from the behaviour to the thinking and information, it makes sense. And I get stuck on threes because we used to talk about a triad of impairment before we, sort of squash it to a dyad. But if you think about a triad of cognitive difference, then the things that really underpin this is impaired abstraction, a relative strength in visual processing compared to linguistic processing. So think about that from a deficit as impaired linguistic processing. And the other one is theory of mind, which is, of course, the ability to put yourself in someone else's shoes and guess what they're thinking and feeling. And people with autism have a relative deficit in that. So if we think about from an impairment point of view, that's impaired linguistic processing, impaired abstraction, impaired theory of mind. And that's really useful when we start to think about adjustments and how to work with people with autism.
So, someone's asked a question about, where you are in terms of function. Is it? I think I've got this question right. Do they sort of function stay, and then they depend on context, or does the level of function shift about as well?
Yeah. Sorry, did you want to?
Yeah, level of function shifts about enormously. So I'll relate just back to my son and the experience I've had with him. Up until the age of 12, we had no real behaviours of concern, no aggression. We had a bit of damage to the house and whatnot. Puberty hit and high school started. And all of a sudden we had a kid who would just walk through a bedroom door or punch holes through walls and would destroy anyone who got in his way. And we had to go down the medication route. Then once he got used to the high school thing and puberty sort of eased, reduction in medication gone, back to functioning pretty okay. High school ended, first week at home with knowing he's not going back to school, off went the behaviours again. So they fluctuate greatly.
And it really depends on the point that you're making the assessment, or the parent's giving the example, or the specialist is looking at the child or asking the questions, isn't it? Again, it's just really so dynamic.
Yeah.
So we'll move to the next slide. I think we've talked about this briefly, but Matt, just go over this one for us. So continual use of words like mild or severe to describe someone with autism or an autistic person is potentially damaging for that person. True or false?
I'm going to go true with this. And again, this is based on personal experience. I've worked with a young man by the name of Thomas Kuzma, who is one of the most energetic MCs that I've ever met. He hosted the last convention for the psychologists for developmental disorders in Sydney. One of the things that he really, really dislikes is people describing his autism as mild or calling him mildly autistic. And as we discussed before, Peter, he relates it to a cup of coffee. It's like, how dare you call my coffee mild? That's not who he is, and he doesn't appreciate it. The other thing that is unique about Thomas himself is that Thomas prefers to be called an autistic person. He does not like to be called someone who has autism spectrum disorder. And what we were going to discuss that just briefly is that if you have any questions about how to address a person with autism, ask them. Ask what their preferences are. Ask what the family's preferences are. Do you prefer that we use the term a person with autism spectrum disorder or an autistic individual? They will tell you. It's not a difficult thing to do to ask.
Thank you. And Andrew, you were telling me earlier that sometimes people haven't thought about that as yes. Might be early in their journey. Tell us how you approach that.
Yeah, and it's a complex issue, as Matt said, between, you know, person first and identity or based language. Without going into that, which we could talk about for a long time, you still have to call it something, because to work with someone, if you're actually talking about challenges with adaptation and problems they're facing, to be able to work on it, to give it a name and to externalize it, and to then start to become curious co-observers, if you like, and find a way together to find solutions, it has to have a name. And so, yeah, if the person doesn't have a preference, then working on that with them to find something that can be palatable and possibly even fun. Because, and I can't help it, I use narrative therapy all the time, but just because problems are serious doesn't mean you can't have fun working on them. And so, yeah, finding something to call it's important.
Great, thank you. So if you do have any questions, just please put them in the chat box or the Q&A box, and I'll attempt to get to them as we go through. So this is a slide from Adam Walton. So mild autism doesn't mean one experiences autism mildly. It means you experience their autism mildly. And so for me, when I read this slide, that really resonated, and it just made me to internalize that I need to think more about the person looking out rather than me, the person looking in, and trying to understand that experience better. Did that resonate with you too, Matt and Andrew?
Yeah, definitely. Yeah. It's from my line of work, being a behaviour support practitioner, I'm called in because people are experiencing someone's autism quite severely. Quite often it's a very simple trigger that we look for and modify the trigger, and all of a sudden the autism becomes mild. You know, it's it's quite different.
Okay, so we're going to move on to something more personal now. So Matt, as he mentioned earlier, his son Lachlan has autism, and Matt has very kindly agreed to have a bit of a chat to us about that tonight. So this is a beautiful photo of his son Lachlan, and maybe we'll just start with Matt. Just please introduce us to your son. Tell us a bit about him.
Okay, so Lockie's now a 19-year-old boy. That photo's approximately 8 years old. He's 19, 136 kilos and 6'3". His mum is 4'10" and 50 kilos. So it's quite interesting when he decides what he wants to do versus what mum wants him to do. But he is extremely gentle. The reason why we've got the also known as there, Lachlan is non-verbal. He's echolalic in everything he says, in that he will watch YouTube videos and that becomes how he speaks. He has an American accent from using a tap to talk program on an iPad to learn how to speak. And at the time that we had it, they only had an American language. He's fascinated by animals. So you can see he's got a little gecko there. We've got geckos everywhere. Currently, he's fascinated with axolotls. So our greeting of a morning is Lachlan gets out of bed, puts his fingers on his head, walks up to you, puts his forehead against yours and smacks you on the head with his fingers. And that's an axolotl's gills whacking you on the head saying good morning. This is the problem. That's cute at home when we know that it's an axolotl, but when you have a young boy his size in a supermarket and he does it to someone's mother standing behind him, it doesn't look so cute. And it causes a lot of problems, okay? But we have 3 children. We have a daughter a year and 3 months older than Lachlan and another daughter 14 months younger than Lachlan. And to say that they've grown up extremely strong individual young women is an understatement. But it all comes down to having a family that we grew up around Lachlan. He didn't grow up with us, so to speak. So very different way to live.
Well, thanks so much for agreeing to share your son's story with us. So I wanted to just take your mind back briefly before the time where you knew he had autism, and just tell us a little bit about what it was like when you suspected that he was perhaps a little bit different, but you didn't quite know why or what was going on.
Yeah, so basically just introducing our careers at the time of when we noticed something was going wrong. My wife was a beautician and I was a plumber. So I was around, obviously, a lot of strong alpha males who, you know, men don't worry about stuff like that. He's normal, he'll get better. So, and then my wife said to me, we need to do something. And I knew there was something wrong, but I didn't know what. And honestly, up until that day that someone said to us, oh, it could be autism, I had never heard the word said. So, you know, we're talking, he was born 2002, this was 2004 that we started to get on. And the interesting part about Lachlan is he met all of his milestones, and then at the age of 2.5, he started to regress. So he went from saying mum and dad to not speaking to a total regression of behaviours. And unfortunately, at the time, we had people that were in an autism group here who were highly supportive of Dr. Andrew Wakefield's findings and got into our ears, and we thought, oh my God, we've poisoned our son with the measles, mumps, rubella injection, and blah blah blah. So that was the key that went into then, like we said, going in to get all of the diagnoses done.
And getting those diagnoses done, I imagine that was pretty stressful.
Yeah, it was really difficult. You have to remember, at the time we had 3 children, all under the age of 6. I was working 2 jobs to try and maintain a family, and then having to take time off to go to a speech therapist, to an occupational therapist, and to a clinical psych and GP meetings and all the rest of it. And it was for me. I step back now and I think, oh, you know, poor me, like, what were you whinging about? At the time, I thought it was the world's biggest issue. But then I looked at what my wife was going through at the time. She was breastfeeding an infant, going through all of this. You know, it was quite traumatic for her, the whole experience.
Yeah, I bet. And I suspect probably feelings of maybe guilt or what have I done wrong, or I've done something wrong.
Most definitely. The interesting part from us was during the part of the diagnosis was I was asked, is there any autism history in your family? I have no idea. I have 97 cousins. Both my parents come from enormous families, and it wasn't until I mentioned autism to them that my mum went, oh yeah, you've got your cousin who's got this, and we found out that there was 13 members across both sides of the family that had a diagnosis of autism. And that was the first we'd heard about it.
Wow. Yeah. I'm impressed that you know you've got 97 cousins. I couldn't tell you how many cousins I've got. That's a good take-home message from tonight.
We have the family tree on the wall, mate.
Yeah. So you had the process, and then I'm sure that you can remember the day that you went to the specialist. I'm not sure who it was you saw who gave you the diagnosis. I know that was a challenging time. Are you able to share a little bit of that with us?
Yeah, so the actual day that the diagnosis had come, we didn't receive any paperwork at home. We didn't get any emails. We were told to come to an office, and we went there. And the person that gave my wife and I the news that Lachlan had autism used probably the worst wording I've ever heard, and looked at my wife and said, I don't want you to feel bad, but the child you thought you had is dead. And it was just, for Jodie, it was completely and utterly crushing. No mother wants to hear that said about a child, you know, and as a dad, I didn't want to see my wife have that reaction either. I was proud of myself for keeping my cool and not losing the plot. But we then sat there for the next 15 minutes, and we had this black and white document put in front of it that basically said Lachlan has Autism Spectrum Disorder Level 3 and severe global delays. And for people at the time who had no university level understanding of anything, it was really confronting. It was like, what does that mean? What's going to happen to him? Is our son ever going to grow up? Is he ever going to have a relationship? Is he ever going to drive a car? Is he all these millions of questions go through your mind, and I think it is just an instant state of anxiety and panic.
I bet it was. Yeah. And so you and I talked about what what you would have preferred to hear in the real world situation, and some of the words that you would have preferred to have heard. Do you want to tell us some tips to maybe that we can perhaps use ourselves as doctors, or we can reinforce after a diagnosis is made and the shock's starting to settle down?
Definitely. And it's never the story that there's light at the end of the tunnel. There's light all the way through it. There are real positives to raising a kid with autism spectrum disorder. Lachlan puts a smile on everyone's face that he meets. He makes us laugh every day. I mean, I'm still toileting this boy at the age of 19, or this young man now. And it doesn't bother me in the slightest in that. It's actually become quite a funny routine for us when we have to do that. Shaving is, there's a lot of enjoyment and things that you are going to get. The child that you have is still going to love you. You're still going to love them. They're still going to have a life. They're still going to be a part of your family. It's just going to be different. And that's it. And I think a lot of people are afraid of difference, like anything that is different that they don't understand, but helping them to understand that this is not a death sentence. It's not the end of your child as you know it. There are real positives to be had.
Yeah, I remember us talking about this too, and you talking about stressing the need that you're still going to be able to have meaningful, loving relationships with your child, and your child back to you, and I guess to embrace the differences, which is what you've managed to do.
Yeah. And you have to, like, to teach Lachlan shave. I've done I've always shaved my head, but I started letting him shave my head when he needed to learn how to shave. I have so many scars on my head. I look like I've been a professional boxer for 30 years. But do you think he'll use a razor? He'll use one on me, but he will not allow it to touch him. So, see, and that's, people would say, how do you put up with that and tolerate that? And it's like, it's the fun part of watching him learn something, and, part of watching him grow. He's at the capacity now of around a 6 to 7 year old child, with his ability to daily function and look after himself. But at the same time, I still sit back and think, what an incredible achievement for an individual with his diagnosis. Yeah.
Oh, thanks so much for sharing that with us, Matt. I know that can be challenging, and that's just really helpful to hear your experience there. I'm going to zip through the next sort of 19 years of your life and let everyone know that you left plumbing and ended up doing a PhD in autism,
in psychology. Yeah, so
in psychology. Yeah,
my PhD was around the rollout of the NDIS and how it affected carers. And believe it or not, the person who's referenced probably the most throughout my PhD thesis is sitting here with us, Dr. Andrew Cashin.
Well, that's nice.
Yeah.
So the next slide is a bit of research that you wanted to show us, which just to highlight some things, and maybe just keep flicking through so all the bars come up.
Yeah, if you put all the bars up, that's fine. So in 2007, there was a study by Cummins et al. They created a thing called the Personal Wellbeing Index. And when they ran that Personal Wellbeing Index across all different groups of Australians, they found that carers had the lowest combined personal wellbeing of any group they measured. And what they found interesting about it, normally the larger the group you measure, the higher their rating on their scale will go. And they found that the more carers that they measured, the lower their quality of life score, their personal wellbeing score actually became. So I ran with that at the start of my PhD thesis, and I started measuring the personal wellbeing index of carers of children with autism and also carers of kids with other disabilities. And we followed them over a period of 4 years. There was 218 parents of children with autism spectrum disorder, and believe it or not, 219 of parents and carers of kids with other disabilities. And over the rollout course of the NDIS, their personal wellbeing index scores just continually reduced until we got to the end of the rollout. And you can see there, combined, they had a combined score of 47.9, whereas the average normal range for people was 74.9. And ASD, carers of kids with autism spectrum disorders, I think that there's a reason why they came out worse, is because I was working specifically with clients or participants in the Hunter region, which was the rollout area that had a lot of the kids with autism spectrum disorder within that region, and there was multiple issues with the trial area. So there's no.
So there might have been some bias there, yeah. But I think, I mean, that slide really tells me that if I see a parent with and their child who has autism, then I'll make sure I schedule another appointment for the parent by themselves.
Yeah.
For the carer. Yeah.
Yeah.
That's a take-home message. Yeah.
You'll quite often, what I would say to that slide is one thing is that if you're having a child with autism come to see you and they've had the diagnosis for a while, just acknowledge that or understand the parents are going to have this low sense of well-being, and it may display in some of their behaviors or some of how they address you. It's not personal. It's not meant to be offensive. They're just dealing with trauma, and it comes out in that form sometimes.
Yep. So we've got a question from the audience. Either of you can answer this. So this person is a mother of a 3-year-old boy with autism and a 6-year-old who's a bit, their words, quirky. And she's also a GP, this person, and so in both roles, I'm wondering, I guess as a parent and a GP, I'm wondering what percentage of people with autism end up financially independent? Andrew's nodding his head. Maybe you can kick off with this, Andrew. I feel it's something worth knowing in both roles to allow for future planning.
Yeah, there's a paper by Howland and Moss, and it's getting a little bit old, and it lays out the outcomes and a lot of the quality of life measures, but they include things like, employment and attaining a post-high school qualification, having an intimate partner and things like that. So rather than quote a percentage, I think I'd go back to Matt's, is that really it's a very individual thing. We know that there are real challenges and autism is a real disability, and that the outcomes are stark in terms of employment and having an income, living independently. But pulling it into the person asking the question and their child is quite a difficult thing. It's to know that that's very real, that the outcomes to this point are not good, but that doesn't mean that for her 3-year-old or her quirky 6-year-old that at some point may have some features or even under the may actually have autism themselves, but we can't project from where they're at to where they're going. And you quoted or used some quotes off a paper that you found in was it Autistic or Pete, that was from a GP who has autism, and so there's a full spectrum. And I guess this is a wishy-washy answer, but the main point is the outcomes are stark, but it doesn't mean that the outcomes are going to be stark for this particular 3-year-old. And our understandings are getting better. The support that when the NDIS works, and I think Matt's going to talk some more about that, when it does work, it's brilliant, which means that there's services, they're affordable. Eventually with supply and demand, because there's the opportunity to be funded to provide service, there'll be an incentive for more service providers. And so that Howland and Moss outcomes of the last really good study, which was some years ago, doesn't mean that by the time this 3-year-old gets there, it's going to be the same picture.
Yeah, I'll just add here with the NDIS, there are some incredible support strategies coming through right now to help young people with autism get into work. I have a non-verbal client who is now just started an apprenticeship as a mechanic. The mechanics he's working for are incredible. They've given him a dark end of the workshop, and they've put barriers up for noise things. He wears his big industrial earmuffs all day. He doesn't speak to anyone. He comes in, they have a diagram of what he needs to do, and the car comes in and he does it. And he has
fantastic.
a support worker who helps him negotiate the social intricacies. Excellent.
And there's just a comment there was a comment in the question Andrew box that also might depend on the comorbidities such as intellectual disability that may make a difference.
Yeah.
So, and you mentioned an article. So some of the graphs you got earlier was from an article from the Australian Journal of General Practice. I'd never quote from Ausdoc, Andrew. That was from a reputable journal, and it was written by a GP with autism. So that's not hard to find online. We can certainly send it to you later if you'd like to read it. So we better move on because we're running out of time. So the next slide is about the NDIS. So you know, we could talk all night about the NDIS. We won't, I promise. But we do want to spend 5 minutes and pick our expert's brain. So Matt's going to talk about a few points here. So first of all, tell us about this age issue in terms of accessing support from the NDIS, Matt.
Yeah. Okay, so children underneath the age of 7, so 6 years and right up to 355 days the NDIS will go to, they come under what's called the ECEI model of the NDIS. It's early childhood, early intervention. What happens is that if the child is suspected to have a certain level of autism spectrum disorder, there is a good chance that they will get in under the early childhood, early intervention package. The package is basically just one lump sum. It's not broken down into sections of what they can use it for. They get a lump sum of funding for use with OT, psychs, peds, behaviour support practitioners, and that money is used to then ascertain what level of support they may need once they get past the age of 7. But the idea of it is to try and intervene early to try and reduce symptoms or improve outcomes.
Great. And then yeah, that reminds me, because I had a child and their mother come in the other day who was 6.5 saying, I need to see the paediatrician because I now need a diagnosis to continue with my NDIS support.
Yes.
And then, so in terms of, you meant disability advocacy services, tell us a bit about what they are and how they may be helpful to the family and the GP.
Yep. So there's multiple advocacy services available across New South Wales, dependent on their area. There is a map that you can look up through the DSS website that will tell you who the advocacy service is in your area. Predominantly, the ones that I've worked with, the Disability Advocacy New South Wales, they will assist clients to complete an application. Now, that is just in the form of filling out the application form, but they also base it on the severity of the disability the individual has. Is we have a client who has a profound level of autism, a severe intellectual disability, living alone with no one to help them, then the advocacy service will actually help them to obtain doctor's appointments and take them to the doctor's appointments and explain what's going on. There's now also a thing called a coordinator of support P level. So most people in the NDIS have a coordinator of support to manage their supports and their fundings. The P level coordinators of supports are now starting to actually help people access the NDIS. They will tell them what they need to go and do. They will help with them in the application and they will help them with their planning meetings should they be successful.
Right. So that would be a good place for referral to start, find out who the local disability advocacy services are in your area.
Yep.
Yeah. So, and then sometimes the family comes in with a form to complete for the GP, which is always a bit of a heart sink moment for me, because forms are a little bit the bane of my life. But it's particularly stressful for NDIS because of all the stuff in the press around if you fill in the form incorrectly, then it might get not accepted, and what this means in terms for the family and getting access and going through court and all these sorts of crazy things. So you had a brief look for us, Matt, at the section that we may need to complete. So we'll just bring that up on the screen.
Yeah.
So this is the medical section, but it can actually, so you've mentioned it can be completed by a health or an educational professional.
Yes. So if there's a counselor, a school counsellor, a school psychologist, or even a education specialist within the school working specifically in a special needs function that notices issues with the child's performance at school, they can complete this. However, I have yet to see one of the applications be successful where this was filled out by a teacher and not a GP. Just the 2 points on here that I just wanted to stress. 2.3, is the impairment likely to be lifelong? if you even stutter one bit about it being a lifelong disorder, they are not going to get in. Okay, if it's a fluctuating issue that can get in and out, there's a good chance they won't get in. I'll give you one very clear example.
Sorry, Matt, can you just say it again? Are you saying that we can't say it's lifelong? Or that we should say it's lifelong?
You've got to say it's lifelong.
You have to say it's lifelong, yes.
Yeah, if they have any doubt that it's lifelong, they will not get in. I'll give you one really clear example of where this went really pear-shaped for one of my clients. I cannot remember the name for the life of me, and you may be able to help me here. People who are double jointed, she has that throughout every single joint in her body, to the extent that she is wheelchair bound for the majority, and on average 10 months of the year she is unable to get out of a wheelchair. She needs someone to assist her to do everything. The NDIS planner who received her application went, well, she can function 2 months of the year and doesn't need a wheelchair. It's not permanent, and it is not lifelong. So,
right. Okay.
Yeah.
Yep. Okay. So it must be lifelong. And then the other one was has the biggest impact on the success. No, 2.3. Sorry.
And 2.5 was the other
2.5.
one.
Sorry. Yep. Excuse me. Yeah. 2.5. Yep.
Yeah. So if the person has a comorbid disorder, and you don't list the comorbid disorder, the NDIS will not fund them for any supports that relate to the comorbid disorder. So if you get into the NDIS because you have autism spectrum disorder, but you have comorbid severe intellectual disability, then the NDIS will say, well, that support does not relate to the autism spectrum disorder, therefore it's not reasonable or necessary to fund it. It's a real grey area. We're not going to get into it because we'll be here for years.
Okay, so maybe get some advice there. So there's a few comments from an experienced paediatrician in the chat box. One comment says support coordinators are really key, not automatically included in NDIS plans. So warn patients that they need to insist on the provision for support coordination in their planning meetings.
Yep, definitely.
Yep. So can you just put that into English for me so I understand what that means?
Okay, so a coordinator of supports, Lachlan has one. His coordinator of supports will look around for service provisions for Lachlan that will suit his needs. So because of his extreme sensory issues with public things, he has worked tirelessly to find things for, like a farm. There's actually a farm stay that Lachlan goes to once a year. He goes for 3 days and he loves it because there's no one else there but him and one other person and a heap of animals that he can interact with.
So writing on the application that a support coordinator is needed as part of the plan. That's the key point there. Definitely. Okay, yep. And then just re-emphasising that NDIS is for severe and permanent disability, so you have to say that it's lifelong. So thanks for that comment there.
Yeah.
So thanks for that, Matt. I know we could talk about this much more. We don't have time, but maybe we can do another talk on this. So just moving along, because we're getting near the end and we do want to have time to go over some tips for us in our consultations. Just quickly, before we go there, Andrew, we've got one more question, because I love questions. So someone says, I've been told there is no funding for coordinator of support if you're under 7. Do you know the answer to that, Matt?
That is correct. So you underneath early childhood, early intervention planning, they have what is called a plan manager, NDI appointed plan manager, and they are an early childhood specialist. Yeah.
Right. Okay. Thanks for that. So, so we want to spend the last 10 minutes or so just getting some tips, particularly from Andrew, about how to improve our experience of when we're seeing people with autism or autistic people in our consultations or in our waiting room. And we've got a few different scenarios to go over there. So Andrew, do you want to take this away? You tell us some tips about setting up appointments and waiting room and what that means for, someone with autism. I think maybe even thinking about someone like Lachlan when Matt's coming in.
Yeah, no, thanks. And we'll do it very quickly, but of course we could spend much longer. But the actual key to this is thinking about not the behavioural stuff initially, but going to that thinking, information processing stuff. when we think about waiting rooms, often we do think about sensory sensitivities, and when they're looking at the revisions to the DSM, there was really careful consideration as to whether sensory sensitivities were core to autism, and it was found that there's not enough evidence to support that. But certainly, you know, a large number of people with autism do have sensory sensitivities. So looking at the waiting room in terms of noise, you know, lighting, is it fluorescent lighting, and things that might be sensory triggers is a very easy spot to start. But probably the more exciting part is to actually look at the autism and the thinking information processing style. We often forget how social waiting rooms are, and that for someone who has impaired social communication, it can be quite stressful when Betty or Bob come and sit next to them and try and have a chat, and then react badly to what happens in terms of their responses. So scheduling appointments where possible, where the waiting room is going to be less busy, you know, first thing in the morning, immediately after lunch, things like that. Theory of mind is useful to think about not only with social communication, but things like guessing why when you're there at the right time, you're not getting into your appointment, but someone else is, and that sort of being able to put yourself into someone else's shoes and guess that they've been waiting longer or their needs greater is very difficult. So some explanation around that. That's sort of also part of that impaired abstraction. If you've got an appointment at 3 p.m, why aren't you going in at 3 p.m? So finding a way to explain.
I think that's pretty fair for all my patients, to be honest. I don't think you have to have autism to be upset about not going in at 3 o'clock when my appointment's at 3.
And that's a good point. And the difference is between being irritated but being able to realise, well, it's not on time, but I will get my appointment, to that real sense of fear that if I'm meant to have an appointment at 3 and I'm not being called in, am I getting an appointment, and then getting some cascading sort of anxiety following. Yeah. So all those adjustments is just thinking back, you know, understanding that with the impaired abstraction, these guys aren't conceptual learners. They've got a much more chunk style learning thing. So they're not going to draw on past experiences or similar experiences and generalize. And so giving complete chunks of information and checking that the person understands it. And I guess the other thing is that when someone with autism, not being a primarily linguistic process, gets confused, with typical thinkers, we keep piling information onto the penny drops. But the more information you pile on, perhaps the further you get from understanding and clarity. And it's actually being aware that, you know, pulling language back, making it as concrete and as simple as possible is going to potentially work out. And of course, if you can visually augment something, show a picture at the same time as you're trying to explain it, then that potentially will be useful as well. We did have immunisations up just because that was when we started talking, that was something that's very topical at the moment with the COVID immunisations, and the fact that having to have a desensitisation process of not just, you know, ripping in with as most typical thinkers, even if they're a bit anxious, you know, you can rip in and get it done fairly quick. Whereas someone with autism, the degree of anxiety and the avoidance of that, you may actually need to, when the appointment's made, talk to the mum or the person themselves and start to rehearse what's going to happen, when it's going to happen, maybe even set up a social story that you can give them on the way in, allow them to touch, look at an injection, and then overcome it. We've had pretty well nearly 100% success in guys of getting their COVID jabs that have, you know, not wanted needles before that, but it's about having a structured approach to go about that.
Yeah, I think sorry to interrupt you there, but Matt, you've got a story about giving injections. Can you remember what you told me?
Yeah, one of our clients who requires a needle every day for a condition, for down to give them the needle. Everyone thought it was because of needle phobia, but the moment that we got the client to give themselves the needle, we haven't had the behaviour of fighting back since. It wasn't fear of the actual needle, it was fear of the people holding them down that was preventing them from doing the daily routine. I'll just give one tip too about with waiting rooms. With Lachlan, his GP did the most wonderful thing for us. He allowed us to come in the day before an appointment and have Lachlan be in the waiting room just after closing time, and showed him the room he was going to go into. Didn't speak to Lachlan, just a quick wave and a hello, and he got 5 minutes in there looking around. When we brought him back the next day, he was comfortable. It wasn't a new place. So even simple little things like that can make the world of difference.
Yeah.
Oh, that's a great tip.
Mm.
And that, some other concrete stuff, it might be possible to wait in the car as well and to then get called in or off into a little side consult room. So there are other little adaptations that can be made as well.
And we've got preventative health up there. Andrew, what did you want to say about that?
I forgot we had it there. That's a really important one, is that actually people with autism are dying disproportionately early of preventable causes. And the research is sort of showing that whether it's diagnostic overshadowing, is that the behaviours and the problems that present with autism sort of stop the conversations getting to that point. Not sure why, but when preventative measures are sort of identified, ongoing prescription and treatment for them is less than for typical clients. And so thinking about health plans, scheduling assessments and things of that nature is just really important. And it's really interesting in that people with autism often push away anything that's anxiety provoking and think about things that are a way, if you like, of immersing and avoiding difficult thinking, and so obsessive sort of stuff. And so even if they start to get worries about things that a typical person might take to their GP, they'll often not think about going in and seeking help. So talking to carers and supports about organising these health checks is really important. And one other thing was we had a grant in for a grant round, and there was a person with autism on the panel, and we were talking about physical health, and his comment as one of the reviewers was, well, that's not something I hear people with autism talk about. And so it's just been really aware that this is a real deficit we need to be aware of and work on.
Yep.
Thanks, Andrew. And the last dot point there was just to remind everyone about health pathways for the North Coast. They're all around New South Wales, but that's the North Coast one. And with the password, there is quite a bit of information for some referral pathways if you go to that website. So we've just about come to the end of our event. I just wanted to quickly ask Matt one last question because we had a comment there about positive NDIS stories. And I know that you're particularly positive, and with all the negativity around NDIS, I think it would be a good way to finish off tonight's webinar. So can you just briefly tell us about that?
Yeah, and I'm going to use our own personal situation. It's like before the NDIS, we were a family with one income of whatever I could earn. We had no ability to be a couple. We had no ability to be parents to our daughters and do normal things with our daughters that other families would normally do. Holidays, so my wife and I have been married 26 years and never had passports, never been overseas together. We've had 4 holidays in the past 18 years. Okay, and those holidays have been 2-night overstays. NDIS rollout, we've been away now on 2 one-week vacations together without any children. Our daughters have not had to stay at home and look after their brother so we can go and do things. We've had a support worker to do that. He's been engaged in things that we would never have thought of actually getting him to try. Who knew that my son could cook so well? All it took was for him to go to a place where he got the chance to do some cooking with someone, and he loves it. So it's life-changing. The thing that is tough for everyone on the NDIS is the constant going back every year saying, my child is incapable of doing this. Can you please help us? That's the only part that is frustrating for us. The rest of it for us is brilliant. Honestly, I would not be sitting here talking to anyone tonight if it wasn't for the NDIS, because I wouldn't have been enabled to do or achieve what I've actually got to do due to the support that it's given our child.
Oh, that's a great story to hear. We do have one last question. I'm not sure if we're going to wrap this up in a minute. We might need to get you to contact this person directly, but it's someone who works in a hospital, sometimes in the emergency department with trauma situations, wondering, that can be a very stressful situation with someone with autism, lots of noises, bright lights, any advice in that situation?
If there's an independent quiet room available, get them in there. They have a similar room at the Coffs Base Hospital here, we've had Lachlan going there. Quite often that room is used for people having psychotic episodes who are brought in by the police for the inpatient unit. But it's challenging. It's grab the parents, anything they can do that's common that will keep them calm. Anything that the parents can give you. There may be a toy, anything that is just a familiar item that will help them maintain some level of calmness. Don't be scary. Stand back, open body language. Try not to overpower them. Give them some form of a choice if you can.
Andrew, did you have anything to add to that?
No, I mean, I read the question as well, and I thought, I mean, it depends whether they're the centre of the trauma or they're in the bed and exposed to it. But,
yeah.
You know, if it's possible, thinking about, you know, giving them access to things which we may not think of, you know, gaming in the ED might seem a very strange thing, but if that's how you sort of immerse yourself and, you know, find respite from thinking about other things which are particularly stressful, which is what's happening around you, then, yeah, you know, if you can get a parent or a carer to bring that in. One thing we often is often missed in hospitals is how important it is to talk to parents, carers, and even the support workers to find out, how the person does manage anxiety, so that even, you know, it might not seem natural as a typical thinker to think that would work, but it can come up with great solutions. The other thing, of course, talking to parents and carers is what's the person's usual behaviour. And if we're thinking about people with autism who aren't verbal, then often to determine whether someone's in pain or what's happening for them, we have to know what their behaviour is usually like so that we can get the contrast. So you can never talk to parents and carers and to, you know, support workers enough. And hopefully more and more into the future, people will actually arrive in hospital with a health passport where all this is laid out on the forms that are available from Queensland Health. It's got a beauty off the internet. So more and more people are having those to bring into hospital with them so that that's information.
Well, yes, we do have my health record. So that's national. So that should form a form of a health passport. There's a little plug for my health record. And and someone's put up a little note there. I've seen a great sign in a car that says their child has ASD, and in a case of emergency, they may not react as expected. So lots of great little tips coming on tonight. So look, we could talk about this for hours, but our time is up. So thank you so much to Andrew and Matt for being with us this evening, and particularly Matt for sharing your personal story. That's been extremely helpful. Thank you, Andrew. So we'll just go to the last slide and just quickly have a quick read here, if you don't mind. Thanks to our sponsors again, Southern Cross University. Just a reminder that we do have a website where you can access previous webinars. You please email us if you'd like to go on our email list for future education events. Hopefully there'll be an ability to give us some feedback briefly, and just two mentions of some upcoming events. So just to save the date, not to be confirmed, but we think it's going to happen on Saturday, the 2nd of April. There'll be an event for doctors and medical students and specialists and GPs in the region, probably from 12 to 4, called Flood Docs, where we're going to have an opportunity for everyone to talk about their experience with the floods. That's Saturday, the 2nd of April. Just save the date there. And the other one, of course, is our next webinar, which is in another month's time, on the 13th of April, which will be a different topic. It will be with Sam Martin, who's an orthopaedic surgeon in Grafton. So thanks everyone for being with us tonight, and we look forward to seeing you again in 4 weeks.